Okay, so I'm hoping this will work this time. Had a few technical difficulties, but I'm working on a different computer, so hopefully the recording will work this time. As I mentioned earlier, we're going to do case studies in class tomorrow, so I'm hoping that you're able to listen to this before class, or at least you've done your TLOs. I just have this image here so that you guys can refresh your memory on the anatomy of the respiratory system. I'm sure most of you are quite familiar with this from anatomy and physiology, and we talked about it quite a bit in 126. So just making sure that you understand, the trachea goes into the bronchi that go into smaller bronchioles that end into the alveolar sacs. So just being familiar with that, since we'll be talking about bronchitis as well as bronchiolitis. Something else I want to mention is that we talk about nursing interventions and nursing care, and a lot of these respiratory illnesses have similar care to them. We'll talk about making it easier to breathe, so making sure that they have adequate gas exchange and airway clearance. So for those sort of things, we're going to put the head of the bed up and sit them upright, help move them around. When we're monitoring them for respiratory issues, obviously we're going to go ahead and do our respiratory assessment. We're going to look at their respiratory rate, their respiratory effort, what's their rhythm, vital signs, listen to lung sounds, look at skin coloration, mucous membrane coloration, all the typical things that we would do when when we're doing a respiratory assessment. So I probably won't go over that every single time, but you'll want to be familiar with that. So when it comes time to take this exam, or when you're taking care of any respiratory patients, always think back to what would I do for somebody who's having a hard time breathing. Obviously, we always want to monitor and assess, and then think about how we can maximize oxygenation for them and make it easier for them to breathe. So the first thing we'll talk about is the pediatric differences in the respiratory system. McKinney does outline this pretty well for you on page 1030, so I would peek at that if you haven't done that. Children do have smaller and shorter airways. This puts them at an increased risk of obstruction by mucus, edema, foreign bodies. So that's why children tend to have higher rates of episodes of asthma, right? Because their airways are smaller and shorter, and so when they get inflamed and they fill with that mucus, they obstruct more easily. Same with foreign body obstruction. They put something in their mouth, they choke on it, and it obstructs them easier than somebody who's older and has larger airways. Also, infants are nose breathers. You guys learned this in 126. So this is important when they are congested and they're not able to easily breathe through their nose. It's going to make it difficult for them to be able to eat and drink. So that can cause some failure to thrive for them. So we'd want to look at how we can ease that for them. Also, eustachian tubes are more horizontal in children. We're going to talk about this next when we talk about otitis media, but when they're pretty horizontal, it increases the risk for bacteria getting into that middle ear, which then increases the risk of getting an infection there. Last, just with any anatomy system, children can't always tell us when something is wrong, so we're going to have to be able to examine that and find ways that we can figure that out. I missed the tonsillar tissue. So tonsillar tissue is enlarged in children that are usually about 4 to 7 years old, and this can cause obstruction for them. But as we start to age and we move past that 4 to 7 age group, our tonsillar tissue actually starts to decrease in size. This is a normal part of aging. That's why you don't see tonsillitis quite as often in that higher school age, middle age, school age children and older. All right, when it comes time to do our assessment, we've got to think back to 126 and how did we do the respiratory assessment? What information did we take in? So obviously we're going to do a complete history. We want to focus on any respiratory issues the patient has had in the past. So do they have problems with recurrent respiratory infections? Do they have any congenital issues that we should know about? Smoking is a huge thing. So do people smoke in the house? Do they smoke around the children? Are they frequently around smoke? Smoking is known to cause more frequent and severe asthma attacks. Children who are around smoke usually have increased rates of respiratory infections, ear infections, and it also puts them at a greater risk of SIDS. So that's something we want to note. I think you'll see when you do your PEDS rotation that that's something that they ask when the children come in for their well visits. Last, characteristics of the illness. So we want to find out what they're in for. Tell us more about what's going on. So ask about breathing problems. What have parents noticed? Have they heard any audible noises when they're breathing, like wheezing or stridor? Have they noticed any coloration change that might signal that there's some oxygenation issues? Have they noticed any cyanosis? Has there been a cough? If they're coughing, are they coughing anything up, or is it a dry cough? If they are coughing things up, what color are their secretions? Then also noting if they've been around anybody who's been infected. So, if they've been around somebody with influenza recently, or maybe they've been around allergens that trigger them. All right, so this just goes back to the basics from 126. So when we do a respiratory assessment, obviously we're going to count our respiratory rate. We also want to look at the effort and depth. So we know when people are breathing, it should be quiet and it should seem effortless and shouldn't seem like it's something that they're really working on. In regards to respiratory rate, obviously rates are going to be different for children than they are for adults, so you'll want to become familiar with those rates. They can be found in your McKinney book on page 722. And just know that rates are going to vary with age, and they can also vary obviously with emotions, pain, what activity is going on, that sort of thing. Next, we want to look at our mucous membranes and skin, looking for any signs of cyanosis. Symmetry of breathing, retractions, so retractions, nasal flaring, could be signs of respiratory distress, so we'd want to look for that. And then we want to listen to lungs. We want to listen to all those lung fields. We want to listen to anterior, posterior, lateral, and if we hear anything irregular, making sure that we're specific about where we hear that when we document. Lung sounds. So hopefully you guys have had the opportunity to hear some lung sounds that are not just clear. You're starting to become familiar with what some of those sounds sound like. As I mentioned before, when we do check lung sounds, we want to be really specific when we document. If you just hear crackles in the left lower lobe, we want to make sure that we are charting that we heard crackles in the left lower lobe on inspiration posteriorly. You wouldn't want to just chart crackles throughout because you didn't hear them throughout. And then we want to chart what we heard in those other lobes so that it's clear. And then you would want to report that to the physician and be very clear when you do that. So crackles are that sound a little bit like popping. Sometimes people say it sounds like popcorn popping, or like when there's a fire and wood pops. That popping just comes from collapsed alveoli. Sometimes they're collapsed from fluid or mucus. When they pop back open when the person takes a deep breath, so you usually hear crackles with inspiration, that opening back up the alveoli is the popping sound that you hear. Another stridor is something that you should be familiar with. So stridor is a high-pitched wheezing sound that's usually caused by obstruction of the trachea. So this can be from an object in there, if they have foreign body aspiration, or from inflammation. So we often see stridor when somebody has croup. Next is rhonchi. Rhonchi is that low-pitched kind of snoring sound. Sometimes people can do some coughing and deep breathing, and then that rhonchi sound will clear. Wheezing is that high-pitched whistling sound. It's very musical. I think wheezing is probably a sound that most of us are familiar with. Occasionally we can hear it even without a stethoscope. If you're not super familiar with these sounds, I encourage you to kind of do some Googling. YouTube has some nice videos so you can hear the lung sounds. There's also some medical websites that give you examples. All right, the first thing we're going to talk about is otitis media. So otitis media is essentially fluid, an infection or a blockage of the middle ear. As we mentioned earlier, kids eustachian tubes are more horizontal than adults. So this anatomy puts them at a higher risk of getting otitis media. So what happens is usually a child will have some sort of viral infection. They'll have a cold, and it seems like they're getting better from their cold, and then they end up with otitis media. So they get the cold, their adenoids get inflamed, and that obstructs the eustachian tube, so they can't drain or ventilate as normal as they normally would. And what happens is it makes kind of a vacuum in there. And the pathogens in the nasopharynx can travel in there. Fluid will accumulate in there because it can't drain. And then it just is a perfect place for there to be an infection. And then from that fluid in there, it really causes pressure and pain for children. That's why they tend to be so painful when they do have otitis media. You'll see kids grabbing at their ears when they're not able to talk due to the pain. Other things we might see if we have an otoscope to look into their ears is you might see a bulging, opaque tympanic membrane. It might be reddened. Your McKinney actually has a nice photo of this in the book, page 1036. You can see a bulging red tympanic membrane, so you could kind of look at what you might be looking for if you're able to do that. Occasionally you might see drainage. So drainage would be like yellow, greenish color. It can smell bad. That's usually an indication that there's been a perforation of that tympanic membrane. So that's something we'd want to educate patients and their family, that we would want to let the physician know if we notice that. Also, obviously irritability, fever. Sometimes they say vomiting, diarrhea. A lot of times they don't sleep well because they're painful. Let's see. Who's at risk of having otitis media? Usually it's around that, 1 year old, 6 months to 20 months old, they say. They are at a higher risk of getting otitis media, as we talked about, if they're around cigarette smoking. Also, bottle feeders tend to be more at risk because of the position they're in when they're feeding. So breastfed babies tend to be in a more upright position when they eat. Also, they get antibodies from mom. So they tend to not get otitis media quite as often as a bottle feeder would. Usually diagnosed by the provider looking at their ears, so they'll look inside their ears. And then treatment for otitis media is usually managing the symptoms. So things have changed. They used to just give out antibiotics right away when somebody had otitis media. Now they're actually going to do a lot of watch and wait for 48 to 72 hours. What they found is a lot of children will have spontaneous resolution of their infection. So if we just monitor them and then take care of their pain symptoms and their fever, eventually that otitis media resolves and they won't ever need antibiotics. So they kind of base that on some different things, what their assessment shows, how painful the child is, what the fever is like. Some children will get antibiotics right away, but if the child seems to be managing well, then they will watch and wait. If they do prescribe antibiotics, generally it's amoxicillin. If the child has a penicillin allergy, they might get cephalosporin. One thing we want to do is reduce risk factors, so talking to the parents about what puts a child at risk. Are there things that we can modify? Do they smoke around the baby? If they're bottle feeders, talk about having them in a more upright position when they eat. Make sure they're not sending the baby to bed with a bottle, because that laying flat contributes to that. Another thing to think about is if they have a child with otitis media who has chronic issues, we want to talk to them about having their hearing checked. So otitis media can cause hearing loss, so it's really important that they monitor hearing. A lot of times parents don't recognize that their kid is having hearing problems, so it's important that we educate them on following up to have a hearing exam to make sure there's been no hearing loss. Last, surgical management. So for children who have recurrent otitis media, they consider recurrent to be more than 3 episodes in 6 months or 4 episodes in 1 year. Then they might get tympanostomy tubes, so ear tubes is probably what you normally hear them called. What happens is they just insert a tube through the tympanic membrane that goes into the middle ears, and that helps equalize the pressure on both sides of the membrane. That takes away that pressure and pain that the child was feeling. Well, when it relieves that pressure, it also allows the middle ear to, the mucosa of the middle ear to start to heal up and go back to normal. So generally tubes fall out on their own in 6 to 12 months. Most children will have, that's a good enough time that they're able to heal up. Some children do need longer than that, and they'll have to have tubes replaced. All right, so nursing interventions when we're taking care of a patient who might have otitis media. Obviously, this is generally not going to be something that a patient's inpatient for, but you may see a patient who's coming in for ear tubes when you do your outpatient surgery rotation, or you might see a patient come in with otitis media when you're at the pediatric office. So knowing what the nursing interventions are is a good thing to know. So antibiotics, if they do happen to be prescribed antibiotics, we'd want to talk to them about how we deal with antibiotics. So this goes across the board for any time anybody is prescribed antibiotics. We know that we need to teach them to take their medications on time for the number of days that are prescribed. Even if the child feels better on day 5, they need to take until day 10 if that's what's ordered. It's really important that they understand this. Also, not to give antibiotics to another child or person if they're having the same symptoms. We will hear that happening sometimes. Next, they can be given acetaminophen for fever or any pain they might be having. So instruct them on how to do that, how acetaminophen is going to be a weight-based dose, how often they can take it, what's the max dose for the day. When to call doctor, so that's important. So if it's a patient that they're doing a watch and wait on to see if they need antibiotics or not, we'd want to educate them on when to call. So, you know, if the symptoms aren't getting any better, if the fever is increasing, if the child's pain is increasing, then we'd want to contact the physician. Or if there's any signs of rupture of that membrane, or if maybe they are on antibiotics but they're still not getting better, you know, they're not seeing a resolution of symptoms, and they want to call the physician. Next, for patients who have chronic infections, we want to talk to parents about the signs and symptoms of ear infection. Sometimes they don't recognize what those symptoms are. You know, you get patients, they actually bring their kid in for some other reason, and then they recognize that the child has an ear infection, and then it kind of clicks to them, oh, my child hasn't been sleeping at night. So you'd want to explain all the signs and symptoms of ear infection, and then also, if they're that chronic ear infection child, talk to them about having hearing evaluations periodically. Last, we want to decrease the risks. I think I talked about this on the last slide. Teach them about what they can do to decrease the risks for their patient. I think each illness that we talk about has a care plan in McKinney. I've put that page number on the PowerPoint, so you should be able to look at those. You guys need to be looking at your care plans and be familiar with that information that is in your care plan. All right, up next is tonsillitis. Tonsillitis can be bacterial or viral. It's just an inflammation or infection of the palatine tonsils, common in that 4 to 7-year-old age group, so preschool, early elementary. And as I mentioned earlier, it does decrease into middle childhood because that lymphoid tissue starts to shrink. Manifestations that we see, obviously a sore throat. Usually the tonsils are noticeably enlarged, reddened. Sometimes they have white exudate on it. Usually complain of trouble swallowing. You know, it hurts to swallow. They may not want to eat or drink because it hurts so bad. And then they tend to breathe through their mouth, and with the discharge coming through and the infection on their tonsils, they get that foul smelling breath. Diagnostic-wise, they might do a throat culture. They would need a throat culture to test positive to give antibiotics. So if it's bacterial, they would do that. Management, as I said, throat culture positive for bacteria, they prescribe antibiotics. If it's viral, it's just going to be symptomatic treatment. So giving them acetaminophen or ibuprofen for pain. They can gargle with warm salt water. Give them cool liquids. Try to find soft foods that are easy for them to swallow, and plenty of rest. So tonsillectomies, you might see these patients when you do your outpatient surgical peds rotation, so it's important to be familiar with this information. Tonsillectomies are usually performed when children are having recurrent issues with tonsillitis. There is some disagreements among specialists of whether they think it's a necessary thing or not, but you still see quite a few of them. So preoperatively, we'd want to complete a complete history and assessment, right? So we want to get a history, we want to know about any allergies, have they ever had issues, bleeding issues or swallowing issues, what do their labs look like, is their white count good, hemoglobin good, that sort of thing. And then we'd also want to assess for signs and symptoms of active tonsillitis. So we know that usually children having tonsillectomies have frequent tonsillitis. So we want to make sure that they're not actively infected when they do the surgery. So assessing for sore throat, do they have a fever? Do they have an elevated white count? So definitely look inside that mouth to assess that. Anxiety related to surgery. We know that almost everybody going to surgery is going to have some type of anxiety. So think about what we can do to relieve that anxiety. Try to find out what they're anxious about. You know, are they anxious about being separated from their parents? Are they anxious about pain? Are they anxious about not being able to talk? And then try to give them clear, specific answers that they can understand to relieve that anxiety. Last is preoperative education. So even beforehand, we want to be educating them on what to expect, as well as what they should be doing afterwards to care for the child. So we want to talk about them in the importance of hydration. So children can be really scared to drink. You know, they're afraid things are going to hurt, but it's important that they're hydrating well. We don't want them to get dehydrated. That's just going to slow down their healing process. Also, parents tend to under-medicate their children when they're in pain. So we want to teach parents how to do a pain assessment, you know, how they can assess if their child's in pain, and then teach them how to manage that pain. You know, really talk to them about the pain medication that's ordered, and explain to them that, you know, how to manage it, how often it can be given, that it's okay to give the child pain medicine if they're in pain. The more pain they're in, the longer it's going to take for them to heal. So really help parents understand that. Now, postoperatively, the major thing we want to look for is for hemorrhage. So we need to monitor for bleeding. Something you'll commonly see when they have bleeding afterwards is that they'll have excessive swallowing. So you have all that bleeding and they just swallow it down. So you kind of want to pay attention to how much your child is swallowing. Eventually, after they've swallowed enough of that blood, a lot of times they'll vomit up bright red blood, so that would be a sign. Depending on how much bleeding is going on, if it's really hemorrhage, they're probably going to have, their vital signs are going to change. They're going to have that elevated pulse, decreased blood pressure, signs of fresh bleeding. We will want to assess inside the mouth with a pen light. Avoid using a tongue depressor. If you have to use a tongue depressor to see inside, you're going to want to use a sterile tongue depressor, as well as only using it in the front of the mouth. Monitoring ability to swallow secretions. So some may be scared to swallow secretions or just not want to. We could notice that they would have a hard time swallowing secretions, you know, if they're drooling, that sort of thing. It's good to have suction available by the bedside, but we really should only be suctioning if there's some type of airway obstruction. Again, there's a care plan in there. There's also a nice box talking about patient-centered teaching that would be really helpful for you when you're going to surgery to watch a tonsillectomy. Next is croup. So there are 4 different types of croup. We're going to focus on 2. Croup is narrowing of the airway due to mucosal inflammation and edema. Usually croup lasts 3 to 4 days. Usually it's noticed first at night. It's a pretty abrupt onset, and they have that croup, that barking cough. Once you hear it, it's a very familiar sound. You won't forget it. The main goal of treating croup is to maintain patent airway. We want their airway patency to remain. So because they have that inflammation and edema, airway is definitely something we need to pay attention to. So acute spasmodic, as you can see the difference, there's a nice setup here. I think your book has a nice table of the different croups as well. But the different age ranges, the different causes, usually they're viral. Assessment is going to be a little bit different, but really pretty similar. So acute spasmodic croup is usually not as severe as laryngotracheobronchitis. So acute spasmodic can usually be cared for at home. versus laryngeal tracheobronchitis is usually going to be hospitalized for some time. So if we're looking at the spasmodic group, treatment, we're going to focus on educating parents on how to take care of the child at home. So it's important to keep the child calm. Crying just aggravates the airway obstruction. So we want to instruct them to try to keep the child as calm as possible. You know, if they have to do things that irritate the child, try to do it all at once versus throughout the day, keeping them aggravated. If the child is not in respiratory distress, it's good to push the fluids to keep them moist, to keep any fluids they might have moist, and help move any mucus in the airways. Also, cool, humid air can help relieve mucosal swelling. So sometimes taking the child outside at night helps with that. And then it really, you know, when you see these patients in the office, it's important to talk to them about when it's time to take them to the ER. So if the patient can't take fluids, if they're noticing signs of respiratory distress or retractions, nasal flaring, cyanosis, then they should be going to the ER. These patients might be prescribed a corticosteroid, so like prednisone, to help the airway inflammation. Just depends on how severe it is. Moving on to laryngeal tracheobronchitis, as I mentioned, usually these ones are hospitalized more than acute spasmodic group. These patients, we're going to want to monitor them closely. If they don't get hospitalized and they just come through the ER, a lot of times these patients are given racemic epi as a nebulizing treatment with oxygen. That racemic epi helps to decrease laryngeal edema and decrease the risk of bronchospasm or having a bronchospasm. And usually you can see in those 2 hours after getting it that the child almost seems like they don't have croup anymore. It helps a lot. But after those 2 hours, the symptoms of croup can come back. So if it's like an ER child, or if we're looking at a child who's been inpatient and hoping to go home, we would keep them over those 2 hours after the racemic epi nebulizer because we want to make sure that they're maintaining the resolution of the croup symptoms, that they really are breathing well. Sometimes in serious cases, it's possible the child could be intubated, but that would only be where there's severe hypoxia and the child really needed it. Treatment obviously is still going to be the same. We want to push fluids, humidified oxygen, keep the child calm, so we're going to cluster our nursing care. I touched on some of this already. As I talked about in the beginning, like I said, the things we do for respiratory is going to be pretty similar for all of our respiratory illnesses. So airway clearance, we're always going to monitor to make sure our patient has good airway clearance. So monitoring for increased respiratory distress, looking for that nasal flaring, looking for retractions, has their effort of their breathing changed, provide humidified oxygen, monitor vital signs. They may get some anti-inflammatory medications for airway clearance, so dexamethasone or prednisone for inflammation, racemic epi. Maintain fluid balance, so if we're worried about fluid balance with these children, we want to monitor hydration status, so we're keeping eyes and nose, weighing the patient daily, and then offering, encouraging and offering fluids that the child will like and want to drink when they're able to drink. Children who are in respiratory distress, it's sometimes difficult for them to take in fluids when they're focusing on breathing so much. So children who are in severe respiratory distress is usually going to get IV fluids, but the children who are not, we want to encourage fluids for them. Fear. So obviously just being in a different environment, being in the hospital, that's going to cause some fear. So we want to try to provide a calm, restful environment. Encourage parents to be part of the care to help keep the patient comfortable and cluster our care so they have those frequent rest periods. And then teaching parents, so when they're getting ready to go home, what they're going to watch for to be, what are the signs and symptoms of respiratory distress. How to provide adequate hydration, how they'll know if their patient's adequately hydrated, what are the signs of dehydration, how often should they see their child urinating, what should that urine look like when their child does urinate, and also treating any pain or fever with ibuprofen or acetaminophen. Next is epiglottitis. So epiglottitis is inflammation of the epiglottis and surrounding tissue. This is a life-threatening illness. It happens pretty quickly and it can develop into a complete obstruction within hours. So this could be pretty scary for parents and the providers. Usually a child will have a really high fever. They'll want to sit upright, right, because we know that helps them move air a little bit easier. Probably see some drooling because they've got that swelling, so it's hard for them to swallow their drool. It's going to be difficult for them to talk because the air movement's decreased. And then they're having a hard time getting air in and out, so it's a hard time breathing. So with these patients, the main goal is to get them intubated. So when they come in, we want to get a patent airway. So the first thing they're going to want to do, they're not going to want to focus on other invasive procedures. They're just going to want to get this patient tubed. Once a patient's tubed and we know we have a patent airway, then we'll focus on other things like antibiotics. You know, what's causing the epiglottitis, get antibiotics started. We want to manage their fever with antipyretics and monitor oxygenation status. So look at SpO2, look at ABGs, and do a respiratory assessment. Right, next is bronchiolitis. So the most common cause of bronchiolitis is RSV. RSV is really contagious. So when we are taking care of these patients in the hospital, it's important that we are following contact precautions and washing our hands thoroughly. We don't want to be spreading that from patient to patient. We know that this can be a pretty serious illness for young children. So we don't want to be responsible for doing that, for causing spread of RSV. So manifestations of RSV, tachypnea, tachycardia, lung sound changes. So they might have wheezing, they could have crackles, rhonchi. It's going to be individual to that patient. Retractions, nasal flaring. You may see some cyanosis depending on the severity. So what are we going to do to treat them? We obviously want to maintain airway. So we're going to monitor them. We're going to do frequent assessments. Look at their respiratory rate, what's the respiratory effort, monitor SpO2 so that we know that their airway is maintained. Medications, oxygen, they may get some nebulizing treatments to help with the inflammation, and then corticosteroids. A lot of times, like we talked about earlier, prednisone may be given to help with the inflammation. We want to keep the patient comfortable as possible, so we talk about, you know, clustering our nursing care, encouraging parents to be there to room in with a child so that they feel safe and comfortable. And then prevention. So Synagis is something that can be given IM injection. It's given monthly during the RSV season to premature infants that are less than 6 months old. So that's something we'd want to educate parents on that is available to them. There's a care plan in your McKinney on bronchiolitis. Please take a look at that. Nursing wise, we focus on preventing spread. So talking to family members about hand washing, you know, not sharing utensils. We know that adults tend to be have RSV, but it just seems like a small cold to them. But when the child gets it, it has more severe effect on them. And then also monitoring oxygenation. So we do that through our respiratory assessment. All right, I just put this diagram up there, so just recognizing the difference between bronchiolitis and bronchitis. We're going to talk about bronchitis next. So, you know, bronchitis is inflammation and swelling of the bronchi, so the larger branches that come off from the trachea that then go into the bronchiolitis. So the bronchiolitis is the smaller bronchioles that then go into the alveoli. So it's important to know the difference there. All right, so bronchitis usually it is a viral infection most of the time. Usually happens with other upper respiratory or lower respiratory infections or conditions. Bronchitis occasionally can be bacterial. When it's bacterial, that bacterial infection is usually secondary to a separate, you know, to a primary viral infection. So they have a viral infection that's going on, and then it causes the patient to be, you know, it just provides a perfect environment for the bacterial to come in and grow in the patient. That patient gets the bacteria of bronchitis. So patients tend to have a cough. A lot of times the cough starts out non-productive, but then it increases to have some loose secretions with mucus there. Lung sounds, sometimes they might have crackles, sometimes they might have bronchi. They may also have some fatigue, low-grade fever, just dependent on that person. Therapeutic management is going to be symptomatic. So we know when somebody has a viral infection, we tend to treat the symptoms. So, if they have any pain or fever, we're going to give antipyretics. If they're having pain, same, we can give Tylenol or ibuprofen. Nursing considerations, so we want to monitor temperature. If the patient does have a fever, we want to give antipyretic like acetaminophen. We're going to assess respiratory effort, look at their effort going in, what's the respiratory rate, do they seem like they're in respiratory distress, and then we also want to assess secretions. So if they have thick secretions, we want to encourage fluids, and also humidification, or if they're on oxygen, we want to give humidified oxygen. That's going to help keep those secretions loose and easy to cough out. All right, pneumonia. Pneumonia too can also be viral or bacterial. Usually for children under 5, it's generally a virus that causes pneumonia. A lot of times pneumonia comes along with like RSV or influenza. We're hearing that a lot right now with all the influenza cases. Children are ending up with pneumonia. That's causing some issues. What we'll see, the manifestations are going to be different with pneumonia if it's viral or bacterial. They do have some similarities. There's a nice table on your McKinney that you can look at that's a little bit more thorough, but viral manifestations, they usually have a fever, but it can be low grade to high grade. Cough, may have some crackles or wheezing, the general don't feel good stuff like a headache, body aches, tiredness. Their white count's usually less than 20,000 though. And this usually is self-limiting and lasts 5 to 7 days. For bacterial pneumonia, a lot of times this comes after upper respiratory infection first, and then they get a high fever that's a pretty abrupt onset. May have chills, they may have chest pain, chest tightness, may have some diminished lung sounds. You'll see some respiratory distress in them, so retractions, nasal flaring, increased respiratory rate, and their white blood cell count will be elevated as well. So taking care of these patients, a lot of these pneumonia patients will be able to be taken care of at home. It just depends on the degree of the severity. So the severity of their pneumonia is going to guide what kind of nursing care we're going to give. If this patient's hospitalized, though, we're going to do a frequent assessment. We should be assessing them at least every 2 hours. It just depends on how often they need it. I've had children coming into the ER with respiratory issues where I couldn't leave their bedside. I'm doing a frequent assessment on them. That obviously wouldn't be happening at Hackley because they shouldn't need one-to-one care. So at least every 2 hours, and when we assess them, we're just going to be doing a respiratory assessment. So we're looking for any signs of respiratory distress, listening to lung sounds, looking at respiratory rate and effort, look at the color of their skin and their mucous membranes, doing vital signs, checking SpO2. Aiding in breathing, we talked about this already. Head of bed up. Help them change position every 2 hours. This is going to help move around that pulmonary drainage. Coughing and deep breathing. Oxygen, we want to give them humidified oxygen. That humidification helps keep any secretions looser. We want to monitor their SpO2. Fluids, if the patient isn't in severe respiratory distress, then we want to encourage oral fluids. If they have pretty severe respiratory distress, then we're going to maintain IV fluids as ordered. We're going to do eyes and nose. We're going to monitor for signs of dehydration, daily weights, that sort of thing. Conserve energy. So we know that conserving energy helps aid in oxygenation, and that's what these patients need. So we're going to look at ways that we can conserve energy. So we want a quiet, calm environment, limit visitors as much as possible, look for diversional activities for the kids who are eager to get up and move around when we really want them to sit and conserve energy. Medications, these patients are probably going to get an antipyretic for their fever, antibiotics if they're a bacterial infection, and then analgesics for any pain they might have. Sometimes breathing can cause some discomfort when they have pneumonia. Last, we're going to want to educate parents and patients on home management when the patient is going to be sent home. Foreign body aspiration, I talked about this a little bit already as well. Pretty common, or happens most to children aged 6 months to 5 years old. We talked about how they have those smaller airways. so it's easier for things to get lodged in there. Common items are little toys, coins, quarters, that sort of thing, food, grapes, popcorn, nuts. So there's a complete list in McKinney that you can look at if you're dying to know what are the common items that kids choke on. Assessment, if you see somebody, if you see a kid with foreign body aspiration, sudden violent coughing, gagging, wheezing, depending on how much it's obstructing, you might see some cyanosis, possibly vomiting or apnea. So what are we going to do as nurses? We want to educate parents in a non-judgmental way. Parents tend to feel a lot of guilt after their child has aspiration, so we want to make sure that we're not passing judgment, but it is important that we assess their knowledge. What knowledge do they have of safety? Maybe they didn't recognize that whatever their child aspirated on was a choking hazard. So we want to teach them about those things. Prevention is key at this point. So we want to find a way to educate them. Also, it's important, probably talk about CPR and Heimlich maneuver. Sudden infant death syndrome, I feel like maybe you talked about this last semester a little bit, but we're going to kind of focus on the care of the parents after this happens. So sudden infant death syndrome, most common between 2 to 4 months of age. 95% of cases are before 6 months of age. More common in boys, babies with low birth weights, and those from a lower socioeconomic class. So those are those risk factors. Good to know. Since the back to sleep campaign started quite a few years ago, there has been a pretty huge decline in SIDS cases. It's good for you to be aware of safe sleep protocols. That's like babies go to bed on a firm mattress on their back. There should be no blankets, no stuffed animals, no crib bumpers in there. They need to sleep by themselves, no bed sharing. They shouldn't be too hot. It's good for them to use a pacifier, those sort of things. So if you were to be working in the ER when a child came in, it's important to provide calm and compassionate support to the family. Make sure we're not placing any blame, even if they had not followed the safe sleep protocols. Maybe they didn't know. You want to find support groups for them, call the chaplain down. Something that's really important is offering them time with their baby. So asking them, if they want some alone time with their baby, if they'd like to hold their baby, that sort of thing is usually something that parents do want. Sometimes they hesitate and don't want it, but they found that parents who don't spend time with their baby after they've passed usually regret it. All right, asthma. So asthma is something that you'll probably see pretty often. It is a leading cause of acute and chronic illness in children, and it's the most frequent admitting diagnosis in children. So it's possible you might have an asthma child when you are on the peds floor at Hackley. So another good thing to be pretty familiar with. Childhood asthma is usually associated, it can be genetic predisposition, and a lot of times it's strongly associated with allergies. Actually 75 to 80% of kids with asthma have significant allergies. So that can be a big contributor, a trigger to episodes. So inflammation of the airways is a common finding that we see with asthma. So they get the inflammation of the airways, and then they get production of the mucus, and that causes that obstruction. They also can have some bronchospasm and bronchoconstriction. It's good to know triggers. So usually episodes have a trigger that causes the episode. Respiratory infections are a common trigger. It's like the flu, influenza, or an upper respiratory infection. Chronic sinusitis can cause severe episodes of asthma. Exercise is another one. Running is a trigger for over 80% of children. But if they use their bronchodilators before exercise, usually they can prevent these episodes. Certain allergens that ordinarily are harmless to people, pollen, mold, food, animals, can be a trigger event for asthmatic children. Environmental pollutants and irritants, so cigarette smoke, air pollution, strong odors, paint fumes, as well as weather. So cold air can be a triggering event or a change in climatic conditions. So it's important that parents and children, as well as the nurse who's going to be educating, understands that certain triggers can cause those episodes. What do we see with patients who are having an asthma attack? Dry cough is the most frequent complaint for patients with asthma. Wheezing is also a classic sign of asthma that I think we hear a lot about. So all the times when patients come in, you can hear wheezing with your stethoscope. It may get to the point that it's audible wheezing. You don't need your stethoscope to hear it. An important thing to know about asthma is that as your patient progresses through their asthma episode, they may get to the point that they're no longer wheezing or they have absent breath sounds. That's not a good thing, especially if your patient hasn't improved clinically. If they're still appearing to have respiratory stress, if they are having some cyanosis, if they're still in that tripod position and now they have absent breath sounds, what's happening is probably now they're not passing any air. So if you have a patient who has not improved clinically and all of a sudden you can't hear anything, they likely are passing no air through. So that's a bad sign. We want them to have some wheezing. Other signs you might see, obviously we talked about respiratory distress signs, flaring, retractions. You may hear some stridor, higher pulse rate. A lot of times they're restless because they're not getting enough air. Maybe in the tripod position to try to get better breathing, chest tightness, and so on. All right, so monitoring symptoms. So peak flow meter is an important thing you should be aware of. So the peak flow meter helps monitor breathing capacity. It measures the flow of air in the forced exhalation. What happens is that kids who have moderate to severe asthma should be doing peak flow monitoring daily, and they compare that to like their best peak flow readings, and it can help identify the start of an asthma episode even before they're having any symptoms. Also, changes in their peak flow reading can kind of help identify a needed change in their treatment. So maybe their medications aren't controlling them as well as they had been. So it's good to have that. And then the asthma action plan. The asthma action plan is a written plan. It provides details of how to take care of the child at home, how to manage asthma at home, and gives specific reasons for visiting the physician or going to the ER. There's a good example of it in your McKinney book that I would take a look at. Also, just making sure that parents are comfortable communicating with the provider. So they should have open communication and early notification if the child is starting to have signs or symptoms. Medications. So nurses, it's really important that we understand these medications because we give them, but we're likely going to be educating the family on these medications as well. So we need to understand these medications. Generally, asthma patients are going to be treated with a combo of medications, awful bronchodilators, and then also anti-inflammatory agents. They also might have some allergy medications, obviously, because we know that can be a trigger. Most patients, regardless of their severity of their asthma, are going to have an inhaled corticosteroid as a control med. And then what they add on after that for control meds is going to be based on the severity of their symptoms. It's really important that you know which medications are control medications for their asthma and which medications are used as rescue when the patient needs immediate relief. It's also important to know which meds to give first. Do we give our anti-inflammatory first, or do we give our bronchodilator first? So we can talk a little bit more about that in class. But if you think about their mechanisms and what they're doing, would there be a rhyme or reason to the way we do that? Also in Oxygen Lab, we'll talk more about MDIs, nebulizers, and dry powder and how we use those. And then our asthma care plan, similar to pneumonia care plan, we're going to do that frequent assessment. Like I mentioned, if you work in the ER and you have an asthmatic patient come in, you're going to be, depending on how bad their episode is, but you may be with them pretty one-to-one until you get them a little bit more under control. So we want to do a frequent assessment, respiratory rate, effort, rhythm, what's their coloring, what are their vital signs, what have their peak flow readings been. aid with breathing and oxygenation. So like we said, sit them up, have the head of the bed up, monitor their oxygen, give them humidified oxygen, IV fluids if they're still having respiratory distress, or push fluids, find ways to conserve energy, provide medications, and then education is needed for the parents. All right, our last topic, cystic fibrosis. So cystic fibrosis is an inherited chronic disease, generally affects the lungs and digestive system. It also can affect different things like the exocrine system and the reproductive system. We're mostly focusing on reproductive, and we talk a little bit about the GI system. What happens is they get a defective gene, and it causes really thick, sticky mucus, and it clogs the lungs, puts them at high risk of infection, and they end up with life-threatening lung infections. It also obstructs the pancreas, in the natural enzymes that helps us break down food and absorb food gets blocked. So these patients have to take pancreatic enzymes when it's time for them to eat. What do we normally see for manifestations? So it's going to vary widely, and it depends on which organ system is involved. You can have cystic fibrosis and have no involvement with your lungs or your digestive system, and maybe it just affects your reproductive system and you struggle with fertility. That's not as common though. So what we might see is like a dry, non-productive cough. Sometimes they have a cough that is productive, wheezing, frequent lung infections because they are at a higher risk of infection. They tend to also be low body weight because they're not absorbing fats as well as the normal person. Diagnosis-wise, most U.S. states test for cystic fibrosis as part of the routine newborn screening. Otherwise, parents or moms tend to notice that their kids taste really salty when they kiss them. So these kids have a higher sodium content in their sweat, and so they'll do a sweat test to diagnose. All right, so our care plan, or how we're going to take care of these patients. Like I said, McKinney has a really nice care plan you guys are going to look at and become familiar with. A little bit different than your other illnesses. So airway clearance. Your book talks quite a bit about chest physiotherapy. Generally, this is performed by physical therapy or respiratory therapy, and it's done 2 to 3 times a day and as needed. So that chest physiotherapy helps move that sticky secretions that's stuck in their lungs. So that's something they'll have to do at home, and we'll need education on. Also going to provide them humidified oxygen, head of bed up, upright position if they're dyspneic. Infection, like we talked about, prone to infection, so we want to educate them on, really good hygiene measures, make sure that they understand that they should receive routine immunizations, avoid other people who've been ill, wash their hands really well, how to monitor for signs of a respiratory infection. Nutrition, they need a well-balanced diet, but it needs to be high in calories, high in protein, carbs, and then we also want to offer them their favorite food so they'll want to eat it. Sometimes these patients need supplements, so they might have oral supplements, or it's possible they'll have enteral supplements depending on how well they're absorbing. Within 30 minutes of eating all foods, snacks, and meals, they do have to take pancreatic enzymes to help break that food down and have it absorbed by the body. Exercise tolerance, so when we take care of patients with cystic fibrosis in the hospital setting, usually they're going to be having an exacerbation, so they're not going to be able to exercise. We'd actually want to provide them with rest periods and organize our care so that they can get rest. But when they're well, we want to educate them that they should be doing some exercise. So exercising is a really important part of their pulmonary treatment. It helps improve or maintain their lung function, and it's an important part of the management of their cystic fibrosis. Emotional needs, so we know this is a chronic illness. They know that they have a shorter lifespan than others. I think it's around 40 now. It used to be in the teens, so it's better than it was. But they do have a significantly shorter lifespan than most people. So you want to let them talk about their feelings, help them identify support groups that might be helpful to them, other resources, help them identify their support systems that they can depend on. And then home care. Teaching family how to do that chest physiotherapy, or setting up for respiratory therapy or physical therapy to teach them how to do that. Making sure they know how to provide their breathing treatments, making sure they know how to use their inhaler with their spacer, that they know how to use their nebulizer, that they have a nebulizer at home. They might have to help them get equipment. Then also just how to give any other medications that they have, when they should be given, anything they need to watch for, which side effects, and so on. So I think that wraps us up. Here's one last graphic for you guys on cystic fibrosis. I hope this is helpful. Like I said, we're gonna do care plans tomorrow. Not care plans, sorry. We're gonna do case studies and then actually teaching plan tomorrow in class on some of these things. Hopefully that'll help reinforce. So between the TLOs, being able to re-listen to this lecture over and over if you need to, and those case studies, hopefully you'll really get this down. Respiratory illnesses are something you'll see a little more frequently, so you want to be familiar with those. All right, thanks guys.